Sorry, but I changed the title of my talk today from patient management to incidence and natural history of LHON in Japan because there is no officially approved effective treatment for LHON available in Japan by now. I have no COI to be disclosed in this presentation. So have you all heard of Kobe? Kobe is near Kyoto in Japan and is a harbor city surrounded by mountains. The slide shows the Bay Area landscape in Kobe in the evening, which is, people say, $1 million view. And these landmarks are symbols of reconstruction after a big earthquake disaster that happened in 1995 and took over 5,000 lives. And Kobe is also a mecca of LHON research in Japan. I am the 5th professor of the Department of Ophthalmology at Kobe University, but the first professor, Dr. Joe Imachi, was a leading figure in LHON research in Japan in the middle of the 20th century. He treated numerous LHON patients, including the large family shown in the upper part of the slide. And he was also neurosurgeon and did the craniotomy over 1,000 patients, including many patients with LHON. And he clinically found inflammatory changes in the arachnoidal space of the optic chiasm during the surgery in patients with LHON, and also reported histopathological findings of those changes. I became an ophthalmologist the next year after Wallace first reported that mtDNA mutations were associated with LHON. As a graduate student, I had the opportunity to examine the mtDNA of many LHON patients who responded to the call of Professor Imachi and corresponding blood collection. So my first report paper written in English reported that 90% of Japanese LHON patients carry the 11778 mutation. This is how I got involved in LHON research. In 2015, I engaged in the development of the administrative guidelines for LHON and diagnosis in Japan as a board member of the Japanese Neuropathology Society, JNOS. At the time the diagnostic criteria were developed, the epidemiological studies had not yet been conducted in Japan. I oversaw the nationwide questionnaire surveys that were carried out twice in 2014 and 2019 on behalf of JNOS in order to determine the number of newly diagnosed LHON patients that year in Japan. Questionnaires were sent to facilities affiliated with board members of the JNOS and the facilities accredited as experts by the Japanese Ophthalmological Society, inquiring about the annual number of new cases seen, age at onset, gender, and the site of mtDNA mutation. The number of new cases in 2014 and 2019 was predicted to be 117 and 69, respectively, based on these inquiries. In both years, male and the 11778 mutations accounted for about 90% of the cases, with a median age at onset of 37.5 and 31 years, respectively. We roughly estimated the number of LHON patients in Japan in 2019 to be about 2,500, based on the number of new cases in a given year, life expectancy, and the overall Japanese population. The LHON prevalence in the Japanese population, according to this estimate, was 1 per 50,000, nearly the same as in the Netherlands, Finland, and northeastern England. These two national surveys reveal that the yearly new cases of LHON in Japan have a somewhat higher median age of onset than cases reported abroad, and the bimodal age distribution of onset, with peaks in the second and fourth to fifth decades of life. The precise prevalence and natural history of visual function, however, are unknown because these nation surveys are cross-sectional one-year research. In this respect, J. Noss studied the LHON registry project by Electronic Data Collection, or EDC, in 2021, with the eventual goal of determining the total number of LHON patients in Japan. A specific objective is to recruit 1,000 LHON patients by March 2013 from 84 institutions to which the JNOS board member belong, in order to ascertain the natural history of Japanese patients with LHON and to create an external control for potential for future treatment in Japan. But regretfully, clinicians are required to perform the data entry labor themselves because task shifting is primitive in Japan. So we therefore attempt to keep the data to be collected as basic as possible, keeping in mind the workload that physicians have while entering data. That is to say, the items to be entered, age at onset, sex and family history, mtDNA mutation site, best visual, corrected visual acuity, BCVA, at the nadir in the each year, and the latest one in each year, which is annually will be updated, and follow-up duration and systemic illness, and treatment history, including independent treatment. So the registration project had just begun, but an interim data as of November 23rd, 2023, are shown in this slide. So out of the 210 included cases, 163 patients had onsets that occurred at least a year ago and had undergone at least one more visual acuity test after reaching the nadir acuity. So 143 patients, that is 88% of the total, were male. The age at onset was a minimum of 6 years and a maximum of 74 years, with both mean and median age of 33 years, with the same bimodal distribution as in the previous two nation surveys. The age at onset did not differ according to the mtDNA mutation site. So 11778 and 114484 and 3460 were the location of mtDNA mutations in 87%, and 10%, and 1% of the cases, respectively. A further 2% were due to recognized uncommon mutations. So the follow-up period was a minimum of 1 year, a maximum of 60 years, and a median of 5 years, which was significantly shorter for the rare mutation group than for the other mutation groups. So overall, the median logMAR converted final visual acuities in their better and the worse eyes were 1.4 and 2.0, respectively. The 14484 mutant patients showed better final visual acuity than the 11778 mutant patients in both better and worse eyes, as reported previously. The slide shows scatter plots of final visual acuity against nadir visual acuity, age at onset. Red horizontal bars represent logMAR of 1.3, which is a cutoff for blindness according to WHO guideline. So final visual acuity was strongly correlated with nadir visual acuity in both right and left eyes. In other words, the better the native visual acuity, the better the final visual acuity. On the other hand, there are a certain number of patients, especially in 14484 mutant patient group, who have disproportionately good final visual acuity compared to the native visual acuity, and are thought to manifest spontaneous recovery. There was a significant correlation between age at onset and the final visual acuity, both of the right eye and left eye, as well as final visual acuity of both better and poorer final vision eyes. The younger patients had higher final visual acuity. This is the same scatter plot as in the previous slide, but color-coded by the presence or absence of a history of oral idebenone medication. There does not appear to be a clear relationship between the presence or absence of idebenone medication and final visual acuity. So multiple regression analysis was performed with the final visual acuity of the better or worse final vision eye as the objective variable, and age at onset, mutation site, history of idebenone medications, nadir visual acuity, and disease duration as explanatory variables. As a result, age at onset and the nadir visual acuity remained significant explanatory variables. That is, the younger the age of onset and the better the nadir visual acuity, the better final visual acuity. In addition, the final visual acuity of the worst final vision eye was also associated with the mutation site, suggesting that the mutation at 14484 would produce good final vision. Less vision loss by the first year of the disease led to a better visual prognosis, which was consistent with the study previously published for Japanese patients by Mashima et al. So I then looked at the amount of change in visual acuity between the nadir and the final values. There was no significant difference in the amount of visual acuity change in either the right or left eye among the patients with the different mutation identified. So next, I looked at the correlation between the age of onset or nadir of visual acuity and the magnitude of change in visual acuity in 11778 mutant groups only. In univariate analysis, there was no significant correlation between the age at onset and change in visual acuity, but a significant negative association between the degree of change in visual acuity and nadir visual acuity. In other words, the poorer the nadir visual acuity, the greater the degree of improvement in visual acuity. There are also a certain number of cases of improvement of logMAR of 0.5 or more, even in relatively elder patients. The presence or absence of idebenone medication did not seem to affect the amount of visual acuity change. Again, so multiple regression analysis was performed in the change in visual acuity in the right or left eye as an objective variable and explanatory variables that were mentioned earlier. Unlike the univariate regression, age at onset was positively correlated with the amount of visual acuity change. In other words, the younger the age at onset, the greater the change in visual acuity, and thus the greater the improvement in visual acuity. On the other hand, the nadir visual acuity was negatively correlated with the amount of change in visual acuity as in the univariate regression. So the worse the nadir visual acuity, the greater the amount of change in visual acuity. That is, the greater the improvement in visual acuity. So the visual function changes of the current subject is compared with those previously reported. So the reality study, which examined the natural history of visual function in patients with 11778 mutation, reported that approximately 85% of patients had visual acuity of 20 per 200 or logMAR 1.0 or worse, and approximately 48% had off-chart visual acuity or logMAR of 1.6 or worse. About 15% of LHON mutant patients in the current data had a logMAR of less than 1.0. Conversely, 85% of patients had a logMAR of 1.0 or higher, which is nearly identical to the number observed in the reality study. However, the proportion of patients with off-chart vision was slightly lower at 41%, because around 59% of patients had a logMAR of less than 1.6. However, in the reverse, rescue, restore, and reflect studies, which assess the safety and effectiveness of gene therapy for LHON with a 11778 mutation discussed earlier, 44% of the external control of the had a logMAR of 1.0 or less, which is significantly less than the 48.9% in the current study. In these studies, the mean final visual acuity difference between the treatment and the control group reported to be minus 0.3 logMAR, while 45.4% of the 11778 mutant patient in this study also showed an improvement of minus 0.3 logMAR or better. So the current findings might corroborate the earlier discovery that Asian with the 11778 mutation have a better visual prognosis regardless of therapy than non-Asian patients. So, in summary, an annual incidence of newly developed LHON patients in Japan is around 100. The younger the onset and the better the nadir visual acuity, the better final visual acuity. The younger the onset and the poorer the nadir visual acuity, the higher spontaneous visual acuity recovery magnitude. About 20% of patients' eyes, even with the 11778 mutation, show 20 per 200 or better final VCVA. Over 40% of eyes of LHON, even with the 11778 mutation, exhibited 0.3 logMAR recovery from the nadir. So Japanese LHON patients with the 11778 mutation may have better visual acuity prognosis than Caucasians, as reported. So special care may be necessary for interpretation of gene therapy effect in Japanese LHON patients when applied in the future. Thank you very much for your attention.